Hi everyone, I'm Siddhesh Zadey and today I'll be talking about measuring population with timely geographical access to surgical care in India. In 2015, the Lancet Commission on Global Surgery had several key messages for the global health world. There is no UHC without surgical care. Most essential and emergency surgeries are as cost effective as vaccines and other common drugs. Scaling up surgical care has massive returns on investment when it comes to poverty, population level disease burdens. It also estimated that over 5 billion people lack timely access to safe and affordable surgical care, with most of these people living in LMICs. And about one-fifth of these people were thought to reside in South Asia. To improve things, the countries needed to start recording and monitoring surgical indicators and develop national surgical plans. The idea of surgical access proposed by the Commission was multidimensional to include measures of surgical preparedness, delivery, and impact. For example, the basic 4 dimensions could be timeliness to care, surgical capacity, safety, and affordability. Of these, timeliness is the first barrier that a lot of people in LMIC world are unable to cross. If you cannot reach the hospital when you need to, everything else fails. Working on surgical care in India is a challenge. Surgical planning has been a cyclic problem, difficult to crack. In the research realm, regardless of the push during the Lancet Commission years, new and more importantly, subnational data for India is still missing. Similarly, in the policy realm, while there are some quite active small initiatives, any attempts for national planning seem questionable at the moment. A major obstacle being lack of data. So the lack of data leads to limited focus, and limited policy interest does not provide opportunities to collect new data on a massive scale. Specifically, focusing on rural India is important for several reasons. First is the reason of dominant demographic. Even today, over 2/3 of the Indian population lives in rural regions. Next, from decolonization perspective, historically, rural healthcare provision has always been neglected under colonial rule. From a needs-based perspective, high disease burdens in rural areas compared to urban counterparts are well known. So owing to all these reasons, rural health has been a high priority for the government of India in the last 2 decades under the National Rural Health Mission. Further, specifically for surgery, critical need for rural surgical care research was expressed during the National Surgical Forum through the Karat Consensus Statement drafted by the Association of Rural Surgeons of India. In order to at least crack the research side of this puzzle and incorporate the importance of rural surgical care, our aim was to synthesize national, state, and district estimates for timely geographical access to surgical care in India for rural and urban populations. We conducted retrospective geospatial analysis for 2017-2018, exploiting the available data and creating some new data sets. Over 600 districts and 36 states and union territories were included in the analysis. Several different data sources were used to acquire the specific components needed at every step of the analytical pipeline. These are listed on the screen. We had to establish a geodatabase and this will be discussed ahead. Importantly, for travel times, urban-rural area maps, and high-resolution population counts, we relied on publicly available global datasets such as the Malaria Atlas Project, the urban-rural catchment area mapping, and the World Pop dataset. This increases the validity, reproducibility, and transferability of our analyses. We used official government population estimates to validate some of these steps. The primary outcome was the proportion of population in a given region within 2 hours of travel time from their nearest healthcare facility. We also conducted sensitivity analysis for other time thresholds listed on the screen. At the Association for Socially Applicable Research, ASAR, we are currently running a project named Indo-Heal Map. which aims to create an open access integrated geolocations database of all healthcare facilities in India. Based on the inclusion criteria displayed on the screen, we isolated surgical care facilities from all the relevant datasets included in the Indo-Heal map. In total, the current analysis used 20,802 surgical care facilities, of which 9,144 were recorded as teaching hospitals and government-listed facilities, the subset known as NIN plus NHP. More details on the geodatabase can be found in the e-poster numbered 970 being presented this year in CUGH by one of our colleagues, Malika Kulkarni. We proposed a novel raster manipulation algorithm to calculate the necessary outcomes. The overall algorithm flow is displayed on the screen. However, briefly, we binarized the multi-category catchment areas raster cropped for India to get rural and urban areas. Appropriately intersecting this binarized raster with high resolution population counts raster gave us the urban and rural population counts at district and state levels for 2017-2018. We created the travel time rasters by running the least cost Dijkstra algorithm on the friction surface with our geodatabase. Next, we binarized the travel time rasters for specific time thresholds such as 2 hours. The two-step interaction of these binary travel time rasters with binary rural urban area rasters and population count rasters gives us the required population. For example, rural population within 2 hours of travel time from their nearest surgical care facility. Finally, the proportions were calculated based on the counts. The heat map shows the time taken to travel for each 1 kilometer square pixel to its nearest surgical care facility at optimal speed of a motorized vehicle. There are visible differences throughout the country in travel times to nearest surgical care facilities. The densigram shows how the distribution of times is skewed with a long right tail. Very high travel times are seen for hilly and remote regions in the northernmost and northeastern parts of India. There are also patches of long travel times in central India in regions that most likely correspond to tribal and rural places. Nationally, over 99% rural residing Indians were within 2 hours of their nearest surgical care facility, assuming motorized travel at optimal speeds. However, there are caveats that we'll discuss later to this number. In both district and state level maps that you see on the screen, most of the places are above the 95% proportion threshold. However, people in the north and northeast regions seem to be facing problems. This matches the travel time heat map that we saw earlier. Regardless of high proportions for rural residents, the rural regions still perform poorer than the urban regions at all the tested time thresholds. The rural-urban gap reduces as we go towards higher thresholds, and this is expected. The statistical comparison of rural and urban areas for population proportions with timely access to surgical care at 2 hours threshold showed that for districts and states, rural proportions are significantly less than the urban proportions. Our findings should be considered upper bound estimates for geographical access. The big caveat that I mentioned earlier is that we assumed readily available motorized transport and optimal travel speeds. However, this may not be always true for a lot of Indians. A second major issue is that we did not account for whether resources are available at these surgical care facilities or what is the quality of care that is being provided. The state and local authorities need to act on inequalities in geographical access to surgical care. Our estimates can act as situational analysis for national surgical, obstetric, and anesthesia planning. All analyses are open source and can be translated to other LMICs. These are the first ever high resolution subnational estimates for India. We also created separate rural-urban estimates to depict the disparities. We validated some of the newly used approaches and data estimates. We provide reproducible notebooks and dashboards for raster-based population estimation and health facility population coverage. These are some of the strengths of our analyses. As for the limitations and related future work directions, our geodatabase is not exhaustive and contains erroneous points requiring manual intervention. We are working towards Indo-Heel map expansion and validation. Analysis was not conducted for districts absent in the GADM 3.6 version. We need better district matching in the future. Sensitivity analysis using different raster resampling methods needs to be conducted. We also need lower bound estimates. A good way to calculate lower bound estimates would be to look at walking travel times instead of the motorized travel times in the future. Finally, exploratory spatial data analysis needs to be conducted to point to clusters of low access. I would like to thank several people at ASAR and the Gemini Research Center whose contributions were vital for this work. You can check out the references here. Thanks for listening. You can reach out to me at the email IDs or the Twitter handle displayed on the screen. Thank you.